We have 5 presenters here, and it doesn't happen too often that I know all of these presenters quite well for a long time. So it's for me, it's really a pleasure to be hosting this meeting. We have 10 to 15 minutes per presentation, and after that we have time for discussions. Between the presentations, there's time for just a few clarifying questions only. So the discussion, the debate, I'd like to have that after all the sessions have taken place. My name is Daan van der Gouwen. I work at Trimbos Institute doing new drug trends monitoring for many years. But I will not present today. But however, I'd like to give the floor to Dominique Schori. He is from Zurich. He is a philosopher. He's also working at the local government of Zurich for many years, involved in harm reduction also for many years. And now he will talk about the action plan on synthetic opioids in Zurich. The floor is yours, Dominique.
Thank you very much, Dan. Is it working? Yeah, great. The room is much more intimidating than the audience, which is a compliment actually for you. In the next few minutes, I'm going to present our reflections about getting prepared on possible changes on the opioid markets in Europe, with the focus on the city of Zurich, as we are based in the city of Zurich. I want to talk, first of all, a little bit about the background. What was our starting point? We started the discussion around 1 year ago. What were our first thoughts? How was it developed? Then a little bit clarification of terms. It's maybe a good point to do that in terms of synthetic opioids. And then, of course, objectives of the action plan and some gaps that we detected, fields of action, and also measures that we were already being taken. So we know quite a lot about drug markets in general, let's say. So drug markets in general do not respect national borders, regional borders, city borders. So as we as Switzerland are not part of the European Union, of course, that's not up to the interest of cartels. So of course, we will also be affected by synthetic opioids in Switzerland. Drug markets are quite resilient to crisis. There were already a few rumors years ago with the closure of the so-called Balkan route, which is historically an important route of smuggling opium or heroin from Afghanistan. There were concerns about whether there could be a shortage in heroin supply in Europe. There was the pandemic with closure of border, no tourism anymore, restrictions on traffic in general, and nothing happened. I mean, there was no impact on the European drug market, on the drug market in Zurich. So drug markets are really adaptable, so they can quickly adapt to crisis, to changes, to new realities. And the last thing that we know that every monitoring has its blind spots. So we do a lot of monitoring work, others as well, but of course we don't know, nobody of us knows the reality, what's really going on the drug market. So the starting point for us with that discussion about synthetic opioids was the fact that there was a massive decrease in opium production in Afghanistan, which produces most of the opium that is used to produce heroin. There was a massive decrease in the production, as you can see it from the numbers. And on the other hand, we've seen a massive increase or a rapid increase in global production of synthetic opioids and diversification of the market. So new products, new NPS opioids arriving on the market. Almost every week there is one new synthetic opioid arriving on the market. And we have, when we look on the map, like from a perspective from Switzerland, we've seen an increase in cases of poisonings by synthetic opioids in Scandinavian countries, in the Baltic states, but also in the UK and in Ireland. And there was this call for action by the EUDA, I think it was in October, I guess, or September, somewhere over there, to enforce member states to take action, to get into action, to prepare for changes on the opioid markets in Europe. Sometimes we are asked, how's the situation in Switzerland? Is it already threatening. We have, so far we have 2 examples of synthetic opioids in our drug checking service in Zurich. Both are counterfeit oxycodone pills that were imported from the UK, both. We know that because of the source of the telegram shops, which is quite a good thing to know that they were imported from somewhere else, because then we know they are not circulating on the local market so far. But the worrying thing is that there are a lot of telegram shops active on the local market in Zurich, and there is an increasing number of especially young people consuming opioid painkillers and benzodiazepines from those kind of shops. So if those kind of pills are dedicated to telegram shops, it's really worrying for this user group. We have a lot of open questions, of course, still. We don't know really about the impact on the European opioid market, so this heroin shortage or the opium shortage in Afghanistan. We don't know really anything about the time frame, so how long would it take till we see possible changes. And that's the point where we are now. Despite the situation in Afghanistan, we believe that there is a very, very high attractiveness of synthetic opioids independently of the global opium production, because they are really cheap to produce, they are easy to produce, they are very potent, so they are very attractive to smuggle. So there is a high interest by cartels to use synthetic opioids instead of heroin. Also because they can control the whole chain of supply when they produce synthetic opioids on their own. To clarify some terms, I think some of you may also have already consumed synthetic opioids when you had a surgery, for example. So we need to distinct the use of synthetic opioids like prescripted in a medical use versus a non-medical use versus an adulterant. And using synthetic opioids as adulterants is the most worrying, threatening situation for people who are using opioids. And the second one, it's similar in most of your countries, I guess. We had also a lot of media attraction among synthetic opioids with very stigmatizing terms like zombie drugs, Frankenstein drugs, things like that. We are starting now to actively getting engaged with newspapers, telling them it's problematic to use those kind of terms when it comes to synthetic opioids. And the last thing is synthetic opioids are not dangerous because they are synthetic. So we shouldn't make that distinction between natural and synthetic, and natural see as a kind of healthier or less risky. So we had and still have the paradox situation that on one hand we have a unique historical opportunity to anticipate changes on the drug market, because also we as harm reduction organization, we are really good in adapting our service to changes in patterns of consumption, in substances and things like that, but we are not that good in anticipating and getting prepared. And the paradox thing is that getting administrations, governments, organizations into action for a phenomenon that is not existing yet. It's really difficult because there is no opioid crisis in Switzerland right now. Why should we get prepared? Why should we take measures? There is no change on the local market. We had 3 main objectives of the action plan: to increase knowledge, exchange information, then expansion of medical intervention, and raising awareness. I will go shortly into detail what we want to do with that. What we first did, we started with regular-based drug checking. We used a machine that we used for going to clubs, for electronic music festivals, to put it into the drug consumption rooms in Zurich on a regular basis, to have some kind of additional monitoring of this population, just to observe what happens, and also to sensitize people who are using opioids in drug consumption rooms for this possible threats. Then we started to collect feedbacks from people who use drugs about what's going on the market, some small phenomena, maybe some rumors as well. We started to increase our monitoring work in online drug shops, so darknet shops, but also Telegram channels. We started to, we hadn't the case so far, but sometimes we have intoxications in drug consumption rooms that are, let's say, explainable in terms of when there was a lot of alcohol involved, a lot of benzodiazepines involved, and then there is a heroin consumption. It's quite, let's say, explainable why there was an intoxication. But when it's just like there is no explanation, so we are now able to test the residues, so the pipes, the baggies, the syringes, to at least have a look, at least to identify whether synthetic opioids were involved. Then we do share data and knowledge between forensic science, harm reduction, and paramedic services. For example, paramedic service they have almost in-time statistic about naloxone administrations in their service, and we haven't had access before to that data. So it's quite important for us to know whether there are any changes. And we are currently evaluating and possibly implementing rapid test strips. You know that there is a limited, but maybe also added value from rapid test strips. There is a lot of false positive results, especially for stimulants and fentanyl. But still, they may have some kind of value, and we're trying to figure it out. And then we want to expand medical intervention. The first one is establishing a take-home naloxone program. Maybe surprisingly for you that Switzerland doesn't have a take-home naloxone program so far. It's the same situation as it is in the Netherlands. It's only accessible by prescription. It's not covered by health insurance, and it's only accessible by importing it from Germany so far. And we try to change them and also find some creative ways to deal with the legal situation in Switzerland, because we are a bit concerned that till the Federal Office of Public Health is reacting, it's going to be too late. So we need to find also some kind of creative solutions. And then, of course, the opioid agonist treatment, or the heroin-based treatment especially, is a very good way to prevent people from the illegal the risk from the illegal opioid market. So we are figuring out whether there is a possibility to have lower access to the threshold and also to review the prescription practice. 2 minutes? Okay. And then raising awareness, especially among police officers. There are a lot of myths and concerns going on, whether if it's risky of touching fentanyl when we intervene through skin contacts and stuff like that. So we need really to have non-alarmistic, neutral information about potential risks. We need to prepare target group-orientated information, because informing young people consuming opioid painkillers from Telegram shop is something different than people using drug consumption rooms and consuming opioids there. So you need to have different strategies to inform them, to train them, to get involved. Then we have 2 peer projects, one for minors, more recreational users, and one for that is active in the drug consumption room. And of course, training modules and information material. So to conclude, it's I would say a historically unique situation that we can anticipate changes in the drug market. It's a good way to promote harm reduction, because harm reduction is the main answer to handle with that situation. Peer involvement is of course crucial to spread the information, and the collaboration between the different players is also crucial. And it's not politically, it's not that controversial in Zurich, because we have different perspectives and objectives than the police has, but we have a common objective, and that is to avoid drug-related overdoses as far as that is possible. And the international cooperation and the networking is crucial. I mean, many of you are sitting here at the table with the TEDdy network, so exchanging information about what's going on the drug market in neighborhood countries, in other countries in Europe, is really crucial for us to get prepared. Thank you.
Thank you, Dominique. Are there any urgent questions to Dominique at the moment? Otherwise, we can continue with the next speaker. Yes, Marcus? Oh, yes. How to do that?
Like this?
Yeah, probably.
Just a short question. What's an example for a non-alarmistic, no? Is it the word? Non-alarmistic information for exposure to fentanyl? Can you give a short example for it?
For a non-alarmistic?
Yes.
For police officers?
Alarmistic, thank you for the word.
Sorry?
Yes. For a non-alarmistic word, information about exposure to fentanyl.
That you cannot overdose by touching it. That would be non-alarmistic.
And this like, kind of rumor about it's in the air, like aerosol and stuff. No.
I'm not sure if I got the question right, but
no, maybe we can talk.
Okay,
I don't want to take it. Sorry.
Keep that in mind for the discussion, Marcus. Now we move on to the second speaker, which is Elisa Fornero. She is also a member of the TEDdy network for many years, social worker from Torino, Turin, but now she's talking on a completely different subject, which is the European Hair Analysis Network, a pioneer study to investigate the use of NPS and new synthetic opioids in hair analysis. The floor is yours, Elisa.
Thank you, Dan, for your presentation. And I'm here to present this pioneer study that was coordinated by the EUDA and was carried out at local level in the Piedmont region, that is the region where I come from the University of Turin, seeing a cooperation between two departments. This study was created to investigate the unaware intake of drugs, since at that moment drug checking services were not so efficient in terms of technique that we used to analyze, and also in terms of possibility for the person to access a drug checking service. This was because of the funding and also because of the fact that drug checking is still not spread a lot in my region, even though it is a basic level of assistance. And so there was the possibility that from the monitoring system we were missing something. Well, yeah. This was the situation when we created this research. So at that moment, from different data, we knew that NPS market was pretty stable, and also we knew that generally NPS were used for recreational purposes. But since there was also the possibility that NPS could be hidden in the so-called traditional drugs, and especially in party setting, there was a concrete possibility that something was missing in our monitoring system. And also there was previous research that demonstrated that people that declared to have never used bath salts, they tested positive in their hair for synthetic catechins. Then, as for the synthetic opioids, at that moment we knew that there was an increase of synthetic opioids in Europe, and also in the meanwhile a testing method to detect fentanyl in hair was developed. The keratin matrix is very stable, so it is possible to detect drugs inside the hair for a long time. Then, as I told before, this project was coordinated by the UDA and 4 different European countries cooperating in the hair and questionnaire collection. There were Italy, France, Portugal, and Lithuania. Totally, we were able to collect 432 samples, but in this presentation, I will focus only on the Italian result, where we were able to collect 200 samples. What was the methodology that we decided to implement? We created a questionnaire that is based on the EU web survey on drugs, and also at our local level we decided also to investigate not only drugs but to consider the drug set and setting model of Norman Zimberg. And so we also explored the motivation, the settings where drugs were used, and also we asked for some market dynamics. Then coupled to the questionnaire that was self-administered by participants, not too influenced by the researcher, the answers, we asked participants to donate a small sample of their hair, and his hair were sent in a lab and tested for more than 150 molecules. One of the most important things of this research was that the results of hair analysis were reported to participants. So we created, of course, an anonymous code, and the participant could go to a website that is a website of a local outreach project that is called No Travel, to check what actually was inside their hair. Then, minors were not allowed in this research, and specifically we asked to the people that wanted to participate to have used drugs in the last 6 months to be able to see if something was happening on the market. Then, these were the key factor, in my point of view, to realize this research, because basically we tried to integrate different kind of knowledges, the one from toxicologists, the scientists, the one from sociologists, but also we involved harm reduction worker and NHS professional, since without their help it was actually not possible to reach the target that we want to reach. Of course, the most important partner in this research were people who use drugs that agree to participate in this research. And I have also to thank a special local trans-feminist harm reduction collective that are Chemical Sisters, because since Neo Travel project that was supposed to be the main partner in party setting was at that moment not working, Chemical Sisters were doing intervention, and so they were a big help for us to be able to reach people in party settings. This was were the setting of sampling. So basically we collected sample in drug checking or drop-in centers, but we were also able to collect some samples in legal music event at home, thanks to the peer involvement of Chemical Sisters, and also thanks to the cooperation of mobile unit, particularly one mobile unit that is intervening in the last 20 years in the main open drug scene setting of the city of Turin. We were focused on two different target groups, the one from party setting and the one from the low threshold, so people who use drugs heavily. And these are some differences that we discovered, because perhaps for many people in this room this is nothing new, but for workers, for NHS professional, this is something that is not so clear at the moment. There are big differences in the two groups in terms of genders, since, for instance, the 96% of people that don't recognize them in the binary system were met in party setting, and generally in party setting you meet people that are under 35. In the PUDH group, the situation is pretty the opposite, so the prevalence is of males. And also in terms of education and employment, you see also, again, this is a specular situation, so people in party setting are well educated, generally they are also well employed, if we can speak about well employment in Italy, but yes, they have a work, and people in the low threshold, of course, they don't have this kind of things, and basically they are unemployed, so they are not working, or they have some welfare measures. And so this, I think that it is very important to consider also when planning intervention, at least at my country level. As for the drug, we started this research thinking that we could detect fentanyl on our synthetic opioids in low threshold, but at least what we saw from the questionnaire is that people in low threshold are not using synthetic opioids, but they are used for people in party setting, because the 11% of the persons that we encountered and participated in the research declared a current use of synthetic opioids. But another result that was very surprising was about ketamine in party setting, because generally this was a substance that was used in underground settings, in free parties, but in this moment, and especially in the city of Turin, but I would say all around Italy, this substance is used everywhere for people going in clubs, in free parties, but also for people going just out to drink something. Another surprising result was cocaine. So generally, we were used to see in party setting, like the first illegal drug use was cannabis, and in low threshold, the first illegal drug use was heroin. But no, something changed probably, because cocaine is the most used substance, the most illegal substance used in these two kind of settings. Then here we have a concentration range. So you see that the blue row is representing the party setting group, and the yellow one is representing the PUDH group. As you can see, it is possible to notice that the concentration, the medium concentration of ketamine in the hair sample is pretty similar for both target groups. And especially what was very surprising is that there is a significant prevalence of ketamine concentration in persons that are not attending party setting and also that declare a few use of party drugs. So these are the general results about the objective of our project of research. So 42% tested positive for drugs they did not declare. So this means that 1 person in 5 potentially had an unaware intake of an illegal drug or a prescription drugs. As you can see in the PUDH target, 9% tested positive for prescription opioids. And they were only declaring the use of heroin, methadone, benzodiazepine, but generally they tested positive for tramadol or even oxycodone or other synthetic opioids like this. And in this target, I want to focus on the low threshold. There was another result, but I didn't report it in these slides. Because we detected a big number of people, like 27%. I have to speak slower. Whoa. Incredible. That tested positive for trazodone. There was, I would say, a bug in this research because we just asked for prescription opioids and not for other prescription drugs, for instance, pregabalin. We know that in Turin, a lot of people, especially migrants, are using pregabalin. And this is a limit of this research, but it was also surprising that a lot of people had in hair the trazodone, so probably or they are following a treatment with this kind of molecule of prescription drugs, or at least they are buying these pills and these drugs on the street. But I think that the most important unexpected result that we had after this project was that after 7 years of dealing with the local NHS agency and having no result at all, finally drug checking was possible to be carried out in the low threshold settings. And in this moment, the travel project for 2 times per month is able to provide people who use drug heavily with drug checking. I don't know if this is directly related to this kind of project, if it was related to the fact that we were demonstrating the unaware intake of drugs, but this research ended in July, and in September there was the first intervention of New Travel providing drug checking in cooperation with a mobile unit. Perfect. So, what are the conclusions? Cocaine and ketamine are widely spread, and in Italy, especially in party setting, it is very, very popular, the Calvin clinics, so using cocaine and ketamine mixed together. We were very surprised, and as a social worker, I would say also a little bit scared that synthetic opioids are used mostly by people in party settings. NPSUs, as this was a result that confirmed what we already knew, are mainly used in party settings, are not so spread, but sometimes they can be hidden in MDMA or in other so-called traditional drugs. So what we think is that hair testing can be another instrument to monitor drugs, but also an instrument for harm reduction, because with drug checking you can assess the situation at that moment. But many times people ask and report strange effects due to the intake of drugs, but they don't have the drugs in that moment. So perhaps this can be another instrument that we can use also to spread awareness and also to foster for having more drug checking services, because I think that if just at the local level we have 1 person in 5 that had an unaware intake, I think that drug checking should be spread and people who use drugs should be provided with this kind of service.
Okay.
Thank you.
Thank you. Thank you, Elisa. Are there urgent questions to Elisa at this time? No. If not, I'd like to give the floor to Guy Jones. Guy, please speak slowly because Guy is a native speaker of the English language. Guy is also a chemist involved since the start of the loop in the UK and drug checking there. And he's also the data manager for, the TEDdy network. And Guy will tell us a little bit more about current drug checking trends in Europe as part of the correlation network monitoring. Guy, the floor is yours.
Thank you very much, Dan. So, yes, I've been working for more than 10 years now in harm reduction, doing various drug checking. And one of my roles at the moment is with the TEDdy network. We are a collaboration of organizations, the Trans-European Drug Information Network. We have over 20 organizations submitting data in the last year from 12 different countries, and we have now built up a database of over 80,000 drug checking records over the last 6+ years. One of the fantastic things about drug checking services is that we are able to collect unique data by talking directly to service users. And so from this, we find out about the provenance of the samples. We can understand where they come from and think about when we detect a new substance, is this because of accidental mis-selling? Or is it because of actually changing trends in people's tastes, whether they are deliberately consuming new drugs or if they are being mis-sold them by accident and they perhaps, without drug checking, only get picked up by hair testing? For most drugs, the market's changed quite slowly, particularly the classic drugs. We see huge numbers of people consuming these drugs, and so changes don't happen particularly quickly. With the 10 minutes I have today, I want to focus on a few interesting things that we've picked up that are moving quite quickly and that we have really emerged over the last year, particularly. So cocaine is the only kind of mainstream drug I'm really going to touch on. And we saw a really interesting change. You can see the red mark on the chart, a really interesting change, that quite a sudden increase in the purity seen by drug checking services. And this was really driven by a fall in the number of highly adulterated samples coming to drug checking services. So we were still seeing high purity samples as we have been seeing for many years now, but we were no longer seeing low quality samples which had adulterants and cutting agents added to them. However, this trend has really reversed, again, very rapidly. For such a huge market, one of the most popular drugs in Europe and indeed the world, we've seen a really big change in 2024. So this data runs up until June 2024. And we saw these adulterated samples suddenly coming back. We have particularly seen the prevalence of procaine within these samples. So procaine is a local anesthetic drug. It doesn't have any psychoactive effects. It only causes numbness and loss of feeling in areas where it's applied. So if people are snorting it in the face. And so this is something that is also quite limited in the countries. We're not seeing it in every country. In the countries where we are seeing it, we've seen this increase in prevalence from quite low up to around 15% of samples containing it. And this is amongst a backdrop of a market that's quite pure. However, in Spain and France, for example, we see around 5% prevalence, about 1 in 20 samples. And this has been constant for some time. So procaine is not appearing in other substances. We're only seeing it in cocaine. And this really tells us that it doesn't appear to be because of a sudden increase in availability of procaine, but perhaps this is a particular supply chain where it's been deliberately added in at the supply level. Next then, I want to talk about cathinones. We've seen a really significant increase in the popularity of cathinones coming to the drug checking services, and people actually want to consume cathinones. In around sort of 2011 to 2015, pretty much a large amount of the cathinone use that we were seeing was accidental contamination or deliberate contamination, but accidental consumption of drugs like MDMA, of cocaine, of methamphetamine. Now we are really seeing massive popularity relative to that period of 3-MMC and 4-MMC particularly. These drugs seem to have developed a real following of their own, that people want to consume them. And even within that, we are seeing that the prevalence of which drug it is quite different. 3-MMC has been uncontrolled in Europe for up until about 1.5 to 2 years ago, and was sold widely in web shops and on the ClearNet. It became a very popular stimulant with effects somewhere between MDMA and cocaine. And since the market has become now controlled, of course, it's not truly controlled, we still have this demand. People are bringing 3-MMC to the drug checking service, but we have a huge amount of mis-selling. And so we have around 2/3 of the samples that are submitted are being mis-sold, are turning out to be a different drug. An interesting difference in this market is within the UK, where 3-MMC was controlled in 2011, the same time as 4-MMC. And so we did not see really any increased popularity of 3-MMC at this time, but we're now seeing a resurgence in the popularity of 4-MMC, of also called methadone, where people are bringing this to the drug checking service, and it's having a popularity of its own. The level of mis-selling is considerably lower than 3-MMC in Europe, but it is still there. What we don't know at this time, so this is very much an emerging trend, what we don't know at this time is how this is going to stabilize. Will we see a shift, because there's clearly already clandestine production of 4-MMC within the UK? Will we see that clandestine production move to Europe and people will start taking 4-MMC to replace 3-MMC? Or will Europe, in the same way that the UK did, start to develop its own clandestine production of 3-MMC, and that this will become the dominant drug there? So with nitazines are, you're probably well aware of this by this point in the conference, nitazines are a highly potent class of opioid drugs with a similar risk profile to fentanyl class compounds, and also with a similar potency. So 100% pure sample of nitazine would be enough to cause an overdose many times over, even in somebody who was very tolerant to heroin. We are not seeing a huge amount of these compounds at the moment in the data up to June, but again, this is potentially will be a fast-moving trend. We are certainly seeing within synthetic opioids, including oxycodone and tramadol, this is somewhere where we are seeing quite high levels of prevalence, but we do not have large numbers of these substances submitted to drug checking services. So we don't have a huge picture of what's happening here. Within the heroin market, about 5% of samples are showing the prevalence of nitazines. And so this is still only 1 in 20 samples containing nitazines at the moment. This is something I would say is kind of expected given the effects profile of heroin compared to those of nitazines. What we are seeing, and I think is very surprising, is that we have 5% of benzodiazepine tablets containing nitazines. Given that these are different classes of drug, this is quite surprising to us. The data here is absolutely dominated by data from the United Kingdom. We have around 2,000 samples of benzodiazepines tested in the Welsh Weddinos service. There's a huge black market for benzodiazepines in the UK, and we don't see many samples of benzodiazepines submitted to drug checking services in the rest of Europe. The availability of pharmaceutical benzodiazepines in the UK is extremely poor. They're very difficult for people to access, and so it's really filled in by organized criminal groups. So you can see the most popular nitazines in the chart at the bottom there. By far one is metonitazine. So within the family of drugs, it's really focused on this one compound. And we found that just 10 detections of the nitazines were expected by the person submitting the drug. So at the moment, with this data from drug checking services, we're not seeing people intentionally seeking out nitazines. But from reports that we have from qualitative information, it seems entirely possible that these tastes will change and that people will start intentionally seeking out nitazines in the future, particularly if classical opioids like heroin experience a fall in their availability. Pink 2C now. So this is to me as a chemist, a very curious trend, that it is an intentional mix of different drugs, and the uniting theme for these samples, the only uniting theme, is that it's always got pink dye added to it. It can be a mixture of ketamine, caffeine, and or MDMA. One of those can be missing. We also see some samples that contain cocaine. There's a very small number of samples that contain the psychedelic drug 2CB. And this is very, very confusing for people because the name that is sometimes used in Spanish-speaking countries particularly is 2CB, which obviously sounds an awful lot like the drug name 2C. So in the UK, we're making a real push within the drug checking services when we're making publications about this to refer to it as pink 2C, because this distinguishing feature is that it's pink and it doesn't have psychedelic effects generally. Certainly within the drug checking services, we're seeing that it is most popular in Spain. It seems to have first originated in South America, in Colombia, and has made its way to Europe. It's had some popularity in Spain for some time, but now if you can see the light blue section of the graph, its popularity is starting to increase in other countries in Europe, and it seems like it will stick around for some time. This is something that people are actively seeking out and seem to be enjoying. And so I think part of the reason for that is probably the reduced intensity of effects. For many British people, nothing is better than a K-hole on the dance floor, but for the rest of Europe, that doesn't seem to be quite so popular. And so diluting it with some caffeine seems to be something that is a little bit more appealing. Thank you very much.
Thank you, Guy. Are there any pressing questions for Guy at this moment? No? Well, let's move on to Lisha Dara. She's presenting on the also correlation monitoring exercise on new drug trends. Lisha, the floor is yours.
Okay.
We cannot see the slides. Yes, there. Well.
I might just
Yeah,
check because there are two different ones. Yeah, this looks fine. Yeah, hi everyone. As Dan said, my name is Lisha and I work at Correlation. So Dan and I actually worked on this report together. So if there's any very difficult questions, you can throw them his way. But Dan has worked on the report for a number of years. Previously, it was focused more on quantitative data, but we decided to change this and focus on qualitative data last year. So we asked our focal points to conduct focus group discussions. We did this for a number of reasons, but we always try to increase the experiences of people who use drugs, the lived experience of people who use drugs within the monitoring projects. And I think this was a really nice opportunity to do so. And also that this topic maybe doesn't always give voice to people's experiences as much as others. So it's nice to be able to complement drug checking data in this way. So in terms of the methodology, sorry, I have these slides here too. So we had 17 of our focal points conducted focus groups, but there was 22 focus groups in total, which I think was really nice. So although 17 seems quite low in terms of our focal points, we did have 145 participants, and you can see there on the map. And we had a really diverse range of participants as well. So it was at the discretion of the focal points themselves, whether they wanted to separate and have one focus group for people with lived or living experience, or they wanted to have service providers or a mix. So it was up to them. So a number of them did kind of split up in that way. But we had harm reduction professionals, advocates, researchers, and community workers. And again, we wanted to capture their lived experience. So although there was also people from drug tracking services within some of the focus groups, it's not necessarily something that's been like corroborated or anything like that. We're just trying to get their lived experience. Oh, sorry. my accent. So getting into the findings then. So as seen in the other reports, I'm sorry, just to say that the way that the report is structured is we have each kind of group of substances, and then within that each substance and a lot of different information. So it's quite a long report. It's about nearly 50 pages. So I've just tried to pick out some key trends, but it's very difficult to do that in the time frame. But just to, these are the wrong slides, but we'll go anyway. But just to say that, as the other presenters have said, cocaine was by far the most mentioned substance in our focus groups. Maybe slightly different to the findings from Teddy, but they felt that there was rising availability, accessibility, but also purity. And that they felt that there was fewer adulterants, actually, even if maybe that's not the case, but we could talk about maybe how our different projects can complement each other a little bit later on. And also that, it was just used in a lot more diverse groups too. And also a lot of polysubstance use as well. The opposite was found with heroin, which I guess kind of complements as well, but that people were feeling some negative effects or no effects at all from heroin. And that was, again, across the board in all of the cities. That was the finding. Looking at benzodiazepines, I think this kind of moves nicely into benzodiazepines because there was this feeling that people were turning to benzodiazepines a lot more because of the decline in the heroin quality. And again, just that there was a lot of concerns about adulterants. People were buying like street volume, or they're buying things that they feel they're buying Xanax, but it could be anything really. We didn't really distinguish between novel benzodiazepines. It was kind of benzodiazepines in general, but I've listed a couple of them there anyway. If you want to have a look, those are the ones that were mentioned. This is quite a broad grouping. I just put these together just because of timing, but as Guy said, cathinones was a really big one that came up, so really widely used. Again, people buying things they think is 3-MMC, or they're intending to buy 3-MMC, could be 4-MMC or something else completely. The same with pink cocaine. So a lot of the focus groups found that the participants just thought it was dealer leftovers, so whatever was left on the table, which we know is not the case, but that was there's a lot of confusion over the contents of the substance. And again, as we've seen in the presentations so far in the session, and we'll see, I think in the next one too, nitazines and fentanyl are more of a concern than a reality, but I think we have the opportunity to really act proactively rather than reactively. So a number of different kind of diverse groups came up as increasing their substance use as well. So young people, women, and migrants. For young people, there was some very young people, so age around 11 and higher, which is obviously a concern for harm reduction services. And that they were seeking out drugs in general rather than specific substances. With young people as well, we did see quite a rise in ketamine use. So for women as well, increased use. I think that there's also barriers to accessing harm reduction services. A number of cities didn't have gender-specific or harm reduction services. So again, with all of these groups, moving on to migrants as well, there's a lot of challenges that come up for the services themselves. But there's definitely an increase in migrants being involved in both substance use and dealing. And again, with the kind of barriers to accessing services is people who might have comorbidities with mental health. And I think that a lot of times they can't access mental health services because of their substance use, or they might not be able to access harm reduction services because the service is not equipped to deal with mental health. And just in terms of patterns, increased polysubstance use, really, really common, and microdosing as well. And yeah, again, as I said, like migration has affected things quite a lot. The dealer dynamics have been changing. There was a shift from more of like a family-like structure and good relationships with the dealers to this kind of focus on money and financial gain. And the market complexity kind of plays in here as well. So there's a lot of these small dose, quick sales. And that this is also quite a worry because of the issues with adulteration as well. And as you said, that there's these online platforms, as you saw in Zurich, like Telegram and the dark web. I think I've kind of mentioned these ones, and I will a little bit more within the discussion. So I think the main kind of point that I'd like to make is the importance of this qualitative research. Again, it gives voice to people with lived and living experience, and we're able to complement these more lab-based findings and enhance harm reduction strategies. So even if there's kind of a conflicting information between the two, we could maybe examine why this is. And then just that we should really develop and expand harm reduction services across the board. So especially because of this rising trend of polysubstance use, issues with adulteration. Of course, these diverse groups here maybe are not able to access harm reduction services. Also that we should increase drug checking, as it wasn't possible in a lot of the cities, and increase drug consumption rooms and digital harm reduction to combat these kind of issues that are coming up. And then I have a number of recommendations here. I guess I won't go into a huge amount of detail on them. They're all in the report. We have this very fancy QR code here, so you can scan and directly access the report if you like, but it's also very visible on our website too. Thank you.
Thank you, Alicia. That was very quick, in 7 minutes or something like that. Without further delay, I'd like to go to the last, but certainly not least speaker, which is my direct colleague, John Peter Coles. He's also, let's say, a granddad in the European harm reduction movement, almost. Today he will be speaking about harm reduction in times of emerging synthetic opioids in Europe. John Peter.
Thank you very much. If you have colleagues like this, you can imagine that you're prepared for everything. Thank you very much, Dan. Yes. Oh, let's not do your presentation again. Could you? Yeah. I'm very delighted to be in this session. And I will speak on the role of harm reduction in the changing market. So listening to all the previous presentations, we heard about all kinds of market changes or possible market changes. But yeah, okay, thank you. But what could be the implications for services and for harm reduction policies? I would like to go through a couple of trends and then open actually the floor to the possibilities how harm reduction should respond to these or anticipate to possible trends. So I'll first speak very quickly, briefly on harm reduction. You are the specialists, so there will be nothing new on that. Then I'll speak on some current challenges, on the current synthetic opioid situation, and the responses on short-term and longer-term for harm reduction. But first of all, I would like to go back. Whom of you was in Prague 3 years ago? 3 years ago, there was an opening session. No, you can't see it probably. Everyone in the room was wearing masks. It was in the middle of COVID times. There was an opening session on synthetic opioids. Over there, you see Matt Calvert from Estonia speaking. That was in October 2021. Imagine what has. Think of the drug market at that time. What has happened in 3 years' time? That was before the Taliban, Afghan, the opium ban, and that was before the large-scale introduction of nitazenes on the European market. That happened in 3 years' time. Okay, how will the future look like for harm reduction? But first, I would like to go back quickly. Harm reduction started as an innovation in many countries in Europe, also in all of our countries. It was a very pragmatic approach. The idea was to keep health first and keeping people alive. And the major paradigm shift at that time is actually to override the conventions, to prioritize people, to make people more important than criminal laws or more important than state interests. People are the most important. That's one of the key essences of harm reduction. Harm reduction went a long way. It became established in Europe. It became promoted by the European agency. It was voted on and internationally accepted as an essential element in drug policy. Hey, what happened now? But is harm reduction still fit for the current situation? If we look at how our situation in Europe or in the wider world has changed, we see a lot of huge challenges. We see shifting policy priorities. We see decreasing political support for harm reduction. We hear during the numerous presentations, we hear about funding being cut down. And we see a changing market situation in terms of consumers, in terms of market substances, and in terms of motives. Why are people using substances? In this presentation, I would like to focus on one element. That's the drug market. No need to talk about the devastating situation on synthetic opioids in North America. Over 100,000 fatal overdoses over the last year. A couple of years ago, there was a European project focusing on synthetic opioids in Europe, and we interviewed a number of North American experts. And I remember that all of them said, no matter what you do, but start in time, because one way or another, it will come your way. We don't know in which size or how it would look like, but get prepared, because if you don't prepare, then you're always running late. You better get prepared. So nowadays, actually, it's already mentioned by my colleague Dominique. In the EUDA already sent out an alert and strongly urge countries, get yourself prepared, because the markets are quickly changing, and that is actually what's happening right now. A number of countries are already starting with checking the levels of the also my country, in the Netherlands. My institute is the Trimbos Institute, is commissioned by the Ministry of Health to do a research on the level of preparedness. Is the Netherlands prepared for a dramatic rise or change in synthetic opioids? So we are doing a literature study. We are talking with international experts. That's what we've been doing right now. And the next step is that we will talk to stakeholders in the Netherlands. What do you actually need? And what are good practices that we can learn from other countries? So we are right in the middle of this inventory. And I would like to go through a couple of the first of our first results. We see a number of trends in the Netherlands, in Europe. So a number of trends in Europe. The first one is that there is a non-heroin opioid epidemic in the Baltic region. Estonia has a full-blown nitazene epidemic. That market over there is fully unstable. There are a substantial number of health incidents, and it also had all kinds of consequences for the health system. So that's a full-blown market. People are, I spoke to a consumer. I hope that he would attend, but he may not have made it this session. And I interviewed him, and he said he was talking about the good old fentanyl times. That was a time when people had a high on fentanyl. It was very risky. They had numerous of overdoses, but somehow that was manageable. Now the situation with nitazene is uncomparable. That's the situation in the Baltic region. The second one is what we already heard from Guy, is that there are clusters of incidents in other countries like Ireland, Scotland, France. This is simply the result of a couple of phone calls to national focal points asking what's the situation in your country. And it started with clusters of incidents in particular settings, in prisons as well. But in Scotland and the UK, these incidents are growing into a more regular supply of nitazens into the market. And then a third trend that notice is also, I think it's mentioned from Torino and in Zurich, is that there is a slow but steady increase among youngsters who start using, let's say, downers that they buy from the internet, benzodiazepines, tramadol, what they think that might be oxycodone. Look at the situation in Norway, for instance. There are around, I think, what's this figure over there? 23 fatal overdoses of nitazens all over the country among young people. I spoke with the people from the health directorate, and they have no idea what's the background of those people, but they simply see a slow but steady increase of nitazens. You heard a story about on Zurich. Also, more and more younger people who are somehow involved in using pain medication or go on the internet and look for opioids. If this is a kind of a snapshot, a very quick first snapshot of the situation right now, how should harm reduction respond to that? I've got 2 slides on that. First of all, I think in short-term measures, it won't be a big surprise. I think that harm reduction and treatment should really invest and step forward. That's with opioid agonist treatment, adjusting treatment protocols, get people into treatment, wider accessibility of naloxone, even lower the threshold for service delivery, and get people engaged, get peer-led initiatives supported, and rethink the communication between consumers and safer use messages. And there are numerous more. But that's for harm reduction services. But for the health systems, it's important that there is the assessment, that the monitoring systems and the assessment systems and the intervention are closely linked together, and they can act rapidly. Over here, you see a number of messages that I think that are important for health system, for the health systems, and don't forget the prison health systems in and after detention. And keep in mind the impact on care providers. Now, I heard a couple of weeks ago, I heard a story about the impact of the incidents in Dublin, and people had been working there day in, day off to keep people alive. And that was only that enormous burden in the health system, and that was only the result of one cluster of incidents. Imagine that would continue for a while or become prominent. And then my final slide. On drug policy, we know if we think of these these trends, I think that it's inevitable that this should have consequences for drug policy as well, and that we should look for safer spaces, for safe supply, to start controlling the market, start with regulation. If substances are that complex and that dangerous, we shouldn't allow it to be in the hands of God knows who, criminal gangs. Take control of the supply. And I think it's quite important to realize that to start investing. What is the situation of younger people who are search on the internet and start using tramadol over the weekend, or stuff that they think that is tramadol? Invest in other health and social policies, address inequalities and social determinants. There's, I think, a bigger need for a whole system approach, not only on drug policy, but also on health policies and social policies, and engage in the mental health and well-being discussions, thinking of the youngsters, going on the internet. And I think something that I've learned from earlier presentations is that we should learn, that harm reduction should learn from our own flexibility. What happened during the COVID crisis? What happened with harm reduction in Ukraine after the Russian invasion? They were incredibly flexible and incredibly capable of addressing, let's say, basic needs: blankets, food, petrol, cell phones. So it's really, they were able to address, let's say, basic needs. And I think that needs to be the way for harm reduction. And then my last point is that I think that it's a point that harm reduction should also engage in the entire safety and security discussions, not only about safe consumption rooms and safe supply, but also engage in safer communities. It was mentioned during this conference at the opening session by Mr. Alexis Goosdale. He said we can't, if the safety of our communities are so important, we can't leave that to other people. We need to engage in security and safety for ourselves, our workers, our children, our neighbors. So engage in the security discussion. And this wraps it all up. I think for harm reduction, 3 elements are important. Be calm, then be alert, stay compassionate, take care of the people around you, and get engaged in safer communities, because in the end, safer communities are also harm reduction. Thank you very much.
Thank you, Jean-Peter, for this rather grim perspective on the drug landscape in Europe and abroad. Now the floor is open for questions or comments, discussion. So please raise your hand. I will come to step forward to give you the microphone. We have 25 minutes, so yes, there's one in the back. I'll go there. Oh, Jean-Peter. Please mention also who you are so that we know where you're from.
My name is Alex Stevens from the University of Sheffield in the United Kingdom. My question is to Guy and Lisa. The last time we saw an increase in the popularity of methadone or 4-MMC, it was at a period when the quality and availability of ecstasy and cocaine was pretty low in the UK. That is not now the case as far as I understand it. So we got high quality cocaine, really strong MDMA pills, but methadone is increasing in popularity. I was wondering how you explain that.
Yeah, so I think this speaks to the kind of concept that I was talking about of we saw, methadone was really popular in the UK. We had this drought of MDMA where availability was very low, adulteration was extreme, and these cathinones were being used to substitute for MDMA where it wasn't existing. They were really filling a gap in the market. And as a result of this, because they were uncontrolled, they were sold widely and honestly, in some cases as well, by websites that people could buy methadone very easily. And I think as a result of that, I think there were many people who kind of in their teens, in their youth, experienced methadone, actually found that they quite enjoyed it. And after its availability fell for a while, that was then picked up by other cathinones that tried to fill the space that methadone was previously taking. And so there wasn't enough demand, there probably wasn't enough supply of methadone either because the legal supply chains had been cut off. But we came to a point, I would say sort of 2019, where there was starting to be some building clandestine supply of methadone. We do think that 4-MMC methadone is being produced largely in the UK, or certainly if not within Europe. And so, yeah, now we're in this situation where actually methadone has a space of its own, that there is genuine demand for it, that people are interested in it, in a drug in its own right. These other cathinones also got banned, but were not quite as standout, did not have an appeal of their own. And so now methadone is kind of coming back and it's filling a space that almost that people didn't know that they wanted before in kind of 2005. So yeah, I think it's a really interesting phenomenon. And I think that as methadone continues to cement its place in the drugs market, I really think it will be a continuing trend for many years. I think there's real reasons that people enjoy it. It lasts a little bit longer than cocaine. It's much less expensive though than cocaine, but it is less intense than MDMA. It doesn't last quite as long as MDMA. And for many people, the crash is not as bad as MDMA. So it really has this appeal of its own. And yeah, I think its appeal will continue. And I think I look forward to seeing kind of the research that comes out in 5 and 10 years time, looking back at sort of like what happened and how did we get here. I think that will be really interesting.
Thank you, Guy. Thank you, Alex. Yes, Tuka.
Thank you. This is actually kind of both to John Peter and Dominic. John Peter's talk was about analysis of the possible scenarios, the bad ones. And then I saw Dominic's action plan in Zurich, kind of an answer, a preparedness plan that is partly at least already implemented. But you both come from wealthy, progressive drug policy cities and countries, partly also. First question is to John Peter, maybe, that how do you see the Zurich action plan as an answer to your analysis? Is something missing, something important? And the second question is maybe to Dominic, to be equal, that how would you adjust your action plan to a totally different reality, city with moralistic or at least limited possibilities in drug policy and not having much resources?
Thank you, Tuka. Is this working? No. Thank you, Tuka. Like I described in my presentation, is the overview is a kind of a midterm look at all the conversations that we're having with people from Dublin, Scotland, all over Europe, including with the people from Zurich. What I realized that most countries are getting up to speed, and it actually that needs to be done as well. Because when speaking to the people from Estonia, you probably remember that from our collaboration on synthetic opioids as well. The people in 2001, the people in Estonia were astonished that suddenly fentanyl entered their market, and it took them years before they were able to respond properly, but they were struck by surprise. In 2014, again, they were struck by surprise that the market changed again, and they had to start all over. What I think right now is that I hear that most governments, cities, but also services are aware of the quickly changing dynamic in the market, and they are trying to get their act quickly together. And I think, personally, I think that the example from Zurich is, it's a well-established city with a good drug services delivery, but it looks like a very good model for action, communication, and getting things started.
Maybe also to be equal, my answer. The idea of the action plan is not to go out and tell other cities what they should do. We are fully aware of it. I would say it's not only about funding, it's a combination of funding and the political will to spend money to those kind of services, because you especially know it from Scandinavian countries that are wealthy as well, but are not spending their money for harm reduction services. So it's not only the funding, but the idea is just, for us, it's like kind of an invitation to other cities, also to other countries, as we discussed it before, to take in consideration or to start the discussion about how to get prepared. And it could be also smaller steps, different steps, according to the needs, according to the situation in the country. And I think it's a good way to kind of smuggle harm reduction into a political debate. For example, the discussion that we had with the police. First of all, they were afraid of getting intoxicated by touching fentanyl. But then we figured out that usually they are the first at the spot when there is an intoxication. So to motivate them to carry naloxone, to use it to help people, is some kind of, let's say, empowering them to also be part of that discussion. And then they are part of some kind of harm reduction measure without being aware of, let's say. So it's also good to have strategies and also to identify gaps. I mean, the example that you bring up from Ireland, I mean, for a hospital or for a paramedic service to imagine what does it mean on one weekend having 50 or 60 drug intoxication with all your hospitals and emergency centers and stuff like that, just to get it into discussion and start what would we actually do if something like this would happen. This can also really help, like according to the resources that you have.
Thank you, Dominique. Some more questions? Yep.
Thank you all for the presentation. My name is Ralf. I work in Berlin, and I have a question about the focus groups and what you plan in the future, because we joined for Berlin as well with 2 focus groups, and we received valuable information by practitioners and by user groups. What is the plan in the future, and do you also plan other projects for monitoring the market situation and the trends in the different user groups? Thanks.
Yeah, so we absolutely plan to continue with this. We hope that it'll expand to more cities. So we have over 40 focal points. So we only had 17 involved this year, but I think that the data was a lot richer this year. So it'll just be built upon more and more. I'm not sure in terms of other projects related to this specifically. We do, again, work quite a lot with Teddy. So there's definitely opportunity to kind of link up there, I think, as well.
Some more. Getting back, yes.
Maybe if I will just add on that, if there's not immediately another question, I think one of the really important things for Teddy from the qualitative information is it really helps us, like we are collecting literally thousands of drug checking results, and having some of the qualitative comments is really helpful for us to kind of find leads and lines of investigation that we should we should dig into this phenomenon or that phenomenon, that we can now, with these comments about cocaine, kind of look at, well, what are the adulterants that we're seeing here? Could there be one of these adulterants that is responsible for making people feel that cocaine is stronger? Maybe it's having caffeine added to it. So by having this kind of qualitative information is really valuable to us as well, to really know what to do with this incredible amount of data that otherwise you can just get lost in it for days and end up totally down the wrong path.
Yeah. And to add on that, so we have seen various trends emerging while doing the focus groups in the last few years. For instance, pink cocaine was one. It's now really becoming bigger and bigger in more and more countries. And another one was nitazenes. You know, right from the start, we were alerted by the emergence of nitazenes on the market. So it's really added value, and it also adds another layer because we know we know why people take this substance or why people turn to pink cocaine, and it's added value to the data collected by the EUDA, for instance, because it's quite plain data. It's very important data, but it's plain. We add a layer of the people who use drugs to that data. So yeah, I have a question for maybe Milutin and also Nebojsa. They're from Serbia, getting back at the nitazenes. I was just wondering, you know, if you hear these stories about the UK, for instance, you know, 250 people died last year of nitazene-related drug use. Is it a concern in Serbia, for instance? Are you concerned with nitazenes on the market? I put you on the spot now, but is there something you can tell about presence of nitazenes in Serbia, for instance? Here you have the mic. You can go there.
Thank you for the question. Actually, we are still in the phase of understanding what's happening with fentanyl. So, and there were some alerts end of last year. There were cases in the region, in Croatia, 2 cases of fentanyl, formally, overdose of fentanyl, but in communication with the Office for Traumatic Drugs, it turned out that it was foreigners who actually really accidentally died. But then in Serbia, we had, Nebojsa was fully involved in this. We had several cases of quite unexpected deaths, and we were supposing that these are the result of fentanyl. 4 of them in Novi Sad and even more in capital of Belgrade. And then we alerted also the governmental institutions, which came out very quickly with kind of, no, there is nothing, there was nothing, but we are not sure that it was the case. It's not that just our usual suspicious of civil society against the governmental, but we think that at least it was not explored fully, if it was really the fentanyl case. So we know that that this is happening. We are warning the governments, but something which grandfather Peter said, John Peter said, that we need to prepare in time. I don't think that more or less any country in Southeast Europe is prepared, except maybe Slovenia, maybe Croatia, you know. I don't know about Greece, but actually, especially the new candidate countries, ex-Yugoslavia, nothing for us. Okay. So it will be very useful for us to give this signal to the authorities. I think it was probably the same case with many other countries from Eastern Europe, not only from our down corner, but and yeah, this is very useful. That's why we are here and to hear all these things. Thank you. Okay.
Thank you, Milutin.
And yeah, just also to say that we are for some years already insisting on having wider naloxone distribution. Naloxone is in most of the countries currently available only in selected emergency ambulance teams. And then we organized a meeting in Serbia with authorities, and they were more or less all there. And then we just simply understood that there is no reason why it is not available in every city, at least. It's cheap. It can be ordered through a kind of annual procurement, and just simply nobody is asking for it, you know, and nobody cares that there are people dying of overdose. So now we are thinking of how do we kind of push people to at least have like a set of maybe 20, and just in case. So still, it's even lazy. It's not easy situation with the naloxone or fentanyl, and then nitazenes, who knows when. Thank you.
Thank you. Some more comments or questions? Perhaps I have a question for Elisa on her analysis and whether the emergence of nitazenes, whether her analysis could be an early detection method to to see the presence of nitazines in, for instance, in northern Italy or elsewhere. Is that a useful tool, especially in countries and cities where there's no drug checking available?
Well, actually, I don't know if it's already available a methodology to detect nitazines in the hair, because there is a methodology for fentanyl. I'm pretty sure that there's a methodology to detect for the finger, for bloody finger, but I'm actually not sure that there's for nitazine. For sure, since the keratin matrix is very, very stable, yes, it can be effective to detect also small amounts.
Okay, thank you. Any last thoughts? A funny thing. Well, we are looking for a funny thing, Milutin.
To check the new system of drug analysis. So we provided a piece of hair of a person who used cocaine to the authority to check if the new instrument offered by European Union in 2014 really works, which was installed like, what was it, 7 years after we received it, you know. Funny.
Thank you very much, Milutin. I think it's time for a warm applause for all the speakers. Thank you very much for attending this session, and we'll see you all tonight at the party at 8 o'clock, I think. Thank you.
Thank you. It's a fancy talking man. Yeah. Put in both ways.